There are various distribution patterns, but surgical, this is the one that Dr. Nassim described as a surgical orientation of describing ureter. Anyone who can tell me about that?
Another one classification is upper, middle, and lower. Upper is above sacroiliac joint. Middle is within the along the length of sacroiliac joint, and the down one is
Correct.
below.
And that the middle ureter that comes in front of the sacroiliac joint is also called as the graveyard area for the identifying relative radial Lucerne stones. And in this picture, there's the importance of knowing the vasculature of the ureter. Okay, along the whole length, anyone, what from which direction the blood supplies come to the abdominal ureter, and along which side blood supply comes to the pelvic ureter.
In proximal ureter, blood supply comes from medial side, and in mid ureter, it comes from the posterior side, and in distal ureter, it comes from the lateral side.
Any surgical importance to this orientation?
Yes, surgical importance is that when we do endopilotomy, we usually do on the lateral side from the proximal ureter, so that blood supply is interrupted.
Endopilotomy, fine with it. And what if you are dealing with a open surgery such as pyeloplasty, or let's say upper proximal uterostomy or distal uterostomy or reimplant? Is there any importance?
We can mobilize wholly from the opposite side from which blood supply is coming.
The main aim is to preserve the adventitia of the ureter segment we are dealing with surgically. So if we know that the abdominal supply, blood supply of the abdominal ureter comes from the medial aspect, that means incision should be avoided, the spatulation should be avoided on the medial aspect of the ureter. Similarly goes vice versa to the distal end. Clear?
So the blood supply to the ureter or the abdominal ureter, it is mainly from the renal artery and testicular or urinary artery, and some ureteral branches directly from the abdominal aorta. And there is the arterial supply will course along the ureter longitudinally, and that creating a plexus of anastomosis. And same as the drainage is carried out by the vessel that is mentioned along the artery that are mentioned here. So we have discussed that
the blood supply, the more we tend to understand the supply of the ureter, we are being a urologist, at least we won't commit such a thing as an injury to the blood vasculature that ultimately can cause the damage to the affected segment of the ureter. Though small, it can later on go fibrotic stenosis and may present with the obstruction, though even partial can damage to the ipsilateral urinary segment or unit. So there, the thing I wanted to point out here is this ureteric orientation. Can you see this goes longitudinal along the entire length this way? That means the जो इसकी ureter की anybody can tell me about the layers of the ureters from inside out? Transitional mucosa, transitional epithelium and mucosa. Lamina propria. They both collectively form mucosa of the ureter. Outside there is muscular orientation, longitudinal and circular. And then comes the adventitia. That adventitia, that outer layer, that carries blood supply along the whole length. In what orientation? This longitudinal orientation. This is why this is very feasible and easy to mobilize the whole ureter along any part of the ureter, the whole length, away from the surrounding viscera, without damaging the adventitia. If there is damage to the adventitia, that may later cause the damage to the affected part of the ureter.
So, as already mentioned, that the blood supply of the proximal ureter is medially and it's surgically important. the mid ureter is posteriorly, and for the distal ureter, it's laterally. The epidemiology, the ureteral injury is very rare. Overall incidence is less than 1%. But of all urological trauma, roughly 1 to 2.5% are ureteral trauma. And pyrotogenic trauma, the commonest cause, is the common cause, approximately 80%, and most commonly involved the pelvic ureter. And among the surgery, the commonest is the hysterectomy, which is around 54%, followed by colorectal surgeries. For penetrating trauma, account for most of the non-iatrogenic injury. The mode of injury it's up two types: the external traumatic injury and the iatrogenic injury. The external traumatic trauma may be penetrating trauma or blunt trauma. The penetrating trauma is the most common, and it accounts 60 to 77%, and especially in gunshot injury. The blunt trauma, about one third of cases, mostly motor vehicle accident, and it can be because of deceleration result in the eversion of the ureter at the ureteropelvic junction. It is most common in children because their spine is more mobile, which allow the spine hyperextension, and that cause ureteropelvic junction eversion. Also associated with fracture of the lumbar process, thoracoabdominal lumbar spinal dislocation, and it's most commonly involve the upper ureter, while the iatrogenic injury most commonly involve the pelvic ureter. The mechanism of iatrogenic ureter injury include either it can be caused by the crush injury, like applying the clumps, or by the ligation to the ureter, or transaction partial or complete, and the ischemia because of the electrocoagulation or ureteral stamping or resection of the ureteral segment, and ingulation. Like in this picture, this is a partial transaction, and here it is a total transaction. This is a ingulation, and this is the ligation, and this is because of the ischemia due to electrocoagulation, etc. The severity scale for uteric injury, according to the American Association Surgical Trauma, uh, grade 1 is hematoma, and there is a contusion or hematoma without devascularization. And the second is the laceration less than 50%. Third, laceration more than transaction more than 50%. And grade 4 laceration, complete transaction with less than 2 centimeter devascularization. And grade 5 eversion with more than 2 centimeter of devascularization. And this is the grading system for URS, ureteroscopic lesion scale, and it showing that there is will be no lesion at grade 1, and per grade 0 and per grade 1 there will be just a mucosal lesion or significant hematoma or edema. Per grade 2 there will be submucosal lesion, and per grade 3 there will be perforation with less than 50% of partial translocation. Per grade 4 there will be more than 50% of partial transaction, and per grade 5 there will be complete transaction. The risk factor for the ureteric injury, the top of the ureteric injury has no identifiable risk factor, and other factor which are contributing, like it is close to the female genital tract, that's why it is commonly injured, like in gynecological surgery like hysterectomy, and the other congenital anomalies of the ureter. The pathological risk factor, the ureteric displacement because of advanced malignancy or previous surgeries, or there is diverticulitis, previous pelvic surgery, or endometriosis. The technical risk factor because of the massive intraoperative hemorrhage, it can cause injury to the ureter because of the coexisting bladder injury. But the occult ureteral injury occur more often than reported, and not all injury are diagnosed intraoperatively. The diagnosis of the ureteric injury, that high index of suspicion should be maintained, and for penetrating external trauma that made intraoperatively during laparotomy, blunt trauma and iatrogenic causes that are much of the time presented delay. The external ureteral trauma usually accompanies severe abdominal and pelvic injury. Penetrating trauma is associated with vascular and intestinal injury, while the blunt trauma is associated with concurrent abdominal or pelvic injuries. So hematuria is an unreliable finding and present in less than one half of the patient with ureteric injury. The iatrogenic injury may be diagnosed intraoperatively, but usually noticed later. Early recognition facilitate immediate repair and provide better outcome. It can be identified intraoperatively by ureteral inspection, like contusion or laceration are often visible. The viability of the ureter may be compromised when the ureter is a dusky or lacing capillary repel. We can perform a dye study. Color dye can be administered by IV infusion, by direct infusion into the renal pelvis, or by retrograde injection during cystoscopic ureter catheterization, or by doing pyrogram. So, by these technique, we can identify intraoperative injury. The delayed diagnosis clinically present with lung pain, urinary incontinence, vaginal or drain leakage, hematuria, fevers, uremia, and urinoma. And prolonged high output from a surgical drain, and that fluid can be sent for spot creatinine level. If the spot creatinine level will usually be 25 to 50 milligram per deciliter when the fluid is urine, but it will be similar to serum creatinine when it is not urine, means 0.5 to 1.5 milligram per deciliter per normal kidney function. So sending the surgical drain fluid for spot creatinine can help, that is it urine or serous fluid. The radiological diagnosis, we can do a simple.
The drain fluid, let's see, working drain fluid is sent for biochemistry. It should be higher than that of, at least 3 times higher than that of the serum creatinine normal.
So radiologically, we can just perform a simple ultrasound, which will be showing if there is a ligation or injury to the ureter, that will be showing hydronephrosis in the kidney. And then CT urogram, retrograde pyelogram, integrate ureterography, IVP, and MRU. CT urography, multi-phase CT urography is the mainstay technique for a traumatic patient. In CT urography with delayed image of 10 minutes is the modern CT. Actually, the contrast is quickly reaching, so we need a delay image to show the extravasation. And the examination of choice when the ureter injury are suspected, and the finding will be include a contrast extravasation and delay ipsilateral nephrogram, ipsilateral hydronephrosis, lack of contrast in the distal ureter, periureteral urinoma, and medial or circumferential circumrenal extravasation without distal ureter opacification or avulsion injury. And this is a interolateral picture of one of the patient that presented in a clinic, and she was having history of hysterectomy at the age of 25 years, and then she was continually incontinent. Then we performed a CT urogram. This is a single picture. It's difficult to comment on it.
It's not advisable to straight away comment on a single image, CT urogram, but still, can anybody tell me if any pathology we can appreciate in this image? Right side, the curve is not going towards bladder.
On the right side, we can appreciate the contrast going till mid-ureter, but beyond that, we do not see the contrast. So it may represent the ureteral ligation.
Is the whole length, when the whole length of a ureter is opacified, is it normal?
The right side or the left side?
The whole length of ureter is opacified on the left side.
Its torch was dilated. So.
See, okay, yes, Shrijan.
This excretory might be early one because we can see in left side ureter there is hydronephrosis and hydroureter as well. So it's likely that there is a ligation injury at the distal left ureter, and right side we can see there is no hydronephrosis as well, and it's just still clearing the urine. maybe. So one film is not enough.
Okay, the good thing Shijan mentioned is early image. So always it is always advisable to have a delayed image picture of for excluding any ureteric injury. The second thing, the pathognomic of this entire length of ureter on CT urogram is also uh, is not normal. If it is enhancing the whole ureter in a single go. And see the ureter, this could be peristaltic skip of the contrast. And we can see contrast leak over here.
So the principle is that the entire length of the ureter is rarely seen in single film of extraterography because of its peristaltic activity. Otherwise, ureteral atony or obstruction should be suspected when you see the complete length of the ureter on CT. This is the same patient RPG, and that is showing the extravasation of the contrast at the distal ureter. And this is the retrograde antegrade of another patient, and he was having a paired pyeloplasty, and he was presented with this loss of length of the ureter. And we performed retrograde and antegrade, and the intravenous pyelography, incomplete visualization of the entire ureter and the ureteral deviation or dilatation, urinary extravasation, and the hydronephrosis. But one should IVP is unreliable for diagnose as it is negative. Like it is written in a book that much of the time when intraoperative there is a suspicion of ureter injury, you can perform a single shoot IVP, but that's unreliable as it is negative in 60% of the patient. Now, how to prevent iatrogenic injury? For iatrogenic injury, the intimate knowledge of the location of the ureter is important. And then the visualization of the ureter, like we can hydrate the patient and that can help in the identification of the ureter. Careful intraoperative dissection in their proximity, a good hemostasis and intraoperative hydration with diuresis, as already mentioned, and the preoperative stenting, like in many book written that previously it was saying that preoperative stenting is not that much helpful in identification of the ureteric injury. The complication or sequelae of ureteric injury that can cause spontaneous resolution or healing and then can lead to urinoma or urinary ascites, infection in transaction or necrosis with urinary extravasation, and fistula formation like ureterovaginal fistula, uterine fistula, or ureterocutaneous fistula, and then can lead to stenosis or stricture within CDS, loss of renal function. The management for ureteric injury, the aim of ureteric injury management is to there is a reservation of the renal function and the anatomical continuity, and the decision depend upon the time of detection, like it is early diagnosed or delayed diagnosed, the nature of the injury, like it is a iatrogenic or external traumatic injury, and then the site of the injury is management is changed according to the site of the injury, and the general condition of the patient is important. Is it a stable patient or unstable patient? So our management will be consist mainly of two parts. It is the ureteric injury is diagnosed immediately or delay. And for immediate diagnosis, two things are important. Is the patient is stable or unstable? The management for stable patient is different and for unstable is different. If the patient is stable, then ureteral and there is a ureteral perforation, means incomplete transaction during URS. It is usually managed by placement of ureteral stent for 4 to 6 weeks. And same is the principle. If the ureteral perforation or incomplete transaction present in delay term, we can also place a ureteric stent per 4 to 6 weeks. So this is for stable patient and even for delay diagnosis. For intraoperative crush injury, remove the item that caused the crush injury. If the crush injury is minimal and the ureter appear viable, place a ureteral stent. If the crush injury is larger or the viability of the ureter is in a question, perform a surgical repair like ureterotracheostomy, or we can say that simple end-to-end anastomosis. The scenario for unstable patient is different. For complex polytrauma patient and unstable patient, it's best to do a damage control approach. And we have four options for unstable patient. Number first, we will do nothing but plan a reoperation when the patient become more stable, usually within 24 hours. The second we can do is just to put a ureteral stent.
What do you mean by unstable patient? Anyone? Like when we are thinking about doing nothing and then plan the definitive reconstructive surgery later on. Good. Hemodynamical and stable. Intraoperative severe bleeding. Okay. And collateral injuries that may need colectomy. So in such a case, we are trained to keep in our mind to keep the option of damage control, basically. Yes, let's.
So that's important. Like if you are on call and they call you for some patient with ureteric injury, so the first thing is to look is the patient is stable or unstable. So if the patient is unstable, we can perform these we can utilize these four options. Number first, do nothing but reoperation when the patient is more stable, usually within 24 hours, or just put a ureteral stent and into the proximal end of the transected ureter and extrude the stent to the skin, or we can mobilize the ureter, extrude the ureter as a cutaneous ureterostomy, or we can ligate the ureter just above the injury and then we will plan a stage percutaneous nephrostomy. We will be unable to perform percutaneous nephrostomy at the time of surgery, either intraoperative or
It is not even recommended to do further damage in such a case like this. Percutaneous nephrostomy should be done when the patient is resuscitated in the ICU, and then the later uh, do the definitive. And the option two, place a ureteral stent into the proximal end. And then this stent, if available, single J stent or at least pediatric feeding tube can be placed into the proximal part of the transected ureter and should be lied down with the suture with just proximal to the that transected part, so that the feeding tube or this chest stand should not be dislodged into the perioperative course.
but the challenging thing is, or the question will be, when they are call you and the ureter is transected and there is a bleeding everywhere. So in that condition, how to identify the proximal and distal end of the transected ureter? Which maneuver we can use to identify the ureter?
Yes, anyone? Any guess, Walid?
The distal end can be identified retrogradally with the scopy or your passing ureteric catheter. The proximal end, there is a landmark for it to palpate or to check for the iliac vessel, common iliac vessel. We can find the proximal end of the ureter.
Yes, so we can identify the transected ureter just by giving the Lasix or furosemide, and that will be showing the gush of the urine. Or we can follow the common iliac artery, and that will be leading toward the distal ureter. Or we can give methylene blue in the pelvis, or we can just already mention that single shoot IV, but that's negative in 60% patient. Or we can give IV methylene blue, but that's having some complication and contraindicated in pregnancy. So we can perform these maneuver to identify the transected ureter intraoperatively when they call you in gynae or some other procedure. The immediate diagnosis referred immediately, like if it is ligation injury managed by delegation and stent placement, and partial injury repaired immediately with the stent up or urinary diversion via nephrostomy tube. For delayed diagnosis, managed first by a nephrostomy tube when there is hydronephrosis, performed either retrograde or antegrade through percutaneous nephrostomy. Open or robotic assisted laparoscopic surgical repair is necessary in case of failure. So the general principle for delay diagnose and repairs is the proper mobilization, and the debridement should not be extensive, like to convert 1 centimeter injury into 5 centimeter. It should be very meticulous and just to achieve a bleeding edges. And then proper spatulation and the anastomosis should be tension free and watertight with internal stenting and external drain. So the management of the ureteric injury is actually divided into the site of the injury. Is it injury is a proximal, mid, or distal ureter? For proximal ureteric injury, we can do ureteroureterostomy, means simple end-to-end anastomosis, and that is only done for mid and proximal ureter, and when the injury is 2 to 3 centimeter. And the principle is that we will spitulate the proximal and distal ureter 5 to 6 mm, and then we will pass a non-absorbable suture uh, from the apex of the one spitulation to the corner of the other, and same for the opposite direction, and then we will tie it, and then we will anastomose the ureter in interrupted fashion. Renal lessons can help for 5 to 8 centimeter uh, loss, and then ureterocolectomy, although it's a very challenging case, and it is almost equal to partial nephrectomy, where we will be exposing the lower calyx, and then we will anastomose it. So it's a challenging, it is done in a condition when the we don't have enough pelvis, or very fragile pelvis, or very intrarenal pelvis. So in that condition, we have option of ureterocolectomy. For mid-ureter, we have the same ureteroureterostomy if the length is 2 to 3 centimeter loss, or we can do transureteroureterostomy. The TU is actually that's also done for a condition when we failed a Boare or sausage, um, or when there is other contraindication. So for TU, it is useful when the ureter reimplant with sausage or Boare failed, and it is performed by passing the donor ureter toward the recipient ureter, just in the by creating a window or tunnel in the sigmoid colon, and
Mesentery.
just above the inferior mesenteric artery, in order to avoid the kinking of the ureter. And then we will be perform a anteromedial ureterotomy, and then we will perform end-to-side anastomosis. But there are some contraindication for transureterotomy. Can anyone mention it?
Anyone relative contraindications?
The relative contraindication is nephrolithiasis, retroperitoneal fibrosis. The absolute contraindication is if the length of the ureter is too short to bring it to the other side.
It's not the option then. Okay, then there are other nothing.
So the only absolute contraindication when we don't have enough length to bring it to the recipient side. The relative contraindication is Dr. Ulid mentioned, that nephrolithiasis, because there will be difficulty to pass a scope retrograde in transureterotomy. And the other indication, like retroperitoneal fibrosis, or radiation in tritus, and genitourinary tuberculosis, and urothelial malignancy. For distal ureteral injury, we can, when there is a loss of 4 to 5 centimeter defect, we can do ureteric reimplant. Ureteric reimplantation just for 4 to 5 centimeter. But if we are unable to achieve tension pre-anastomosis with ureteric reimplantation, and we need further 5 centimeter length, then we can perform a sausage. The sausage is actually performed by the apex of the urinary bladder is fixed with the ipsilateral side, psoas muscle, and psoas minor tendon. but another the genitofemoral nerve is actually passing through that area, so it should be saved while performing this. And the other important thing is to ligate or discontinue the contralateral pedicle, means the superior vesical artery, that will give you a good mobilization of the ureter to the ipsilateral side. And if still if it's not possible with sausage, then and the anastomosis is undergoing tension, then we can go for Boari plate, and that's will give further to 12 to 15 centimeter defect. And the Boari plate is performed. First, we will be raising a plate, identifying the plate. Then we will raise the plate. After that, we will tubularize the plate, and the tubularized plate is then in anastomosis with the transected ureter. But the issue with long segmental ureteral injury, where we can unable.
Nasim, anyone for sausage and body flap, is there any importance of the if we are doing it in the, obviously there's the option for the elective repairing the injury of the ureter, distal ureters. What is the importance of the bladder capacity? Is it important to know the bladder capacity beforehand? Or in other words, can we say this is a contraindication to the body flap or sausage maybe?
The Boari flap and sausage is usually avoided in the small capacity bladder.
Good. Fibrotic bladder, small capacity bladder. Yeah.
Yes, so the Boari plate is contraindicated. Boari and sausage is contraindicated in small capacity bladder or bladder outlet obstruction. So better to know the bladder capacity before the procedure, or at least urodynamic studies.
Outlet obstruction is not contraindicated, but should be dealt before if we are thinking about doing body flap.
For long segment ureteral injury, we can use ileal interposition graft or autotransplantation and buccal mucosal graft ureteroplasty. So this is the ileal transposition when there is a much more loss of the ureter. And this is the
Show back to the back slide. This part of ilium that has been harvested along with its mesentery, and there are some studies who have reported the Monty procedure. Recently, Dr. Ravi talked about that Monty tube can be also utilized in the same setting, and some have reported they've used appendix for the big defects as well. So this is one of the option if there is a big length of ureter is damaged.
So the buccal mucosal graft is actually done in a condition of complex structure or paired procedures, in which we are just the this is a multi-level structure in which the incision is given through the one side of the ureteral structure, and then the buccal graft placed over it, and then it is wrapping around the mental wrapping. This is taken some from Twitter. This is the same algorithm which we have already discussed. And the algorithm for the type of the injury, these are things we have mentioned. If there is a blunt trauma and there is a gross hematuria or microhematuria with deceleration injury, and the patient is unstable, then intraoperative one shoot IUP is done. If it is normal, then consider other source of hemorrhage. It means there is no ureteric injury. But if it is abnormal, then the potential ureteral injury is present, and then we will explore and repair, considering the damage control surgery as the patient is unstable. Same is for penetrating trauma. The patient, first we will be looking, is the patient stable or unstable. If the patient is stable, then do CT and then proceed accordingly. If the patient is unstable and there is a gross or microhematuria, if it is present, then intraoperative one will be same principle like the one mentioned. And this is the techniques for intraoperative recognition. If there is a minor ureteral injury, then delegate is a necessary stent, means place a stent for 6 weeks and then advise to follow up the patient with retrograde pyelography or stent removal or replacement is needed. If it is successful, then we will just follow the patient with some with renal scan. If it is failed, then we will utilize the other option of delayed treatment, which we have already mentioned. While for major injuries, uh, we will just primary stenting or ureterostomy, the other procedures, and then the concept. If the patient is unstable, then we will consider damage control procedure. And this is the for delay diagnose. For delay diagnose, we will be performing uh, CT with contrast. And if it's showing the minor ureteral injury, the same principle that we will keep a ureter stent for 6 weeks, and then we will follow up the patient. If the surgery, if the stenting successful, then we will remove the stent and we will follow the patient with a renal scan. If it is failed, then we will follow this procedure. Same for the minor, major ureteral injuries.
Any question? Is anyone, if I ask, what is the best modality to diagnose ureteric injury in a elective setting, we say? Imaging study and the RPG is the right answer. It identify not only identify the site of injury, but it excludes if there is a ureteric injury present or no. So takeaway messages: everyone should know to keep in ahead about the damage control approach in setting of call from like polytraumatic unstable patient. And so, thank you, everyone. Thank you.